In cases where a client on warfarin has an INR of 5.8 without bleeding, the best nursing action is to hold the warfarin and notify the provider. This is because an INR between 4.5 and 10 without bleeding requires holding the medication and informing the provider. Administering vitamin K or plasma is reserved for more severe cases. For a client on lithium carbonate experiencing symptoms of toxicity after starting hydrochlorothiazide, the priority action is to hold the lithium and notify the provider for a stat lithium level. Thiazides and hyponatremia can reduce lithium clearance, leading to toxicity. Immediate action is necessary to prevent further complications. When a vancomycin trough level is supertherapeutic at 28 ug/mL with rising creatinine, the best action is to hold the next dose and notify the provider or pharmacist. This is due to the risk of nephrotoxicity, necessitating dose adjustment and careful monitoring. Regarding insulin administration, it is crucial not to mix glargine with any other insulin. Each type of insulin should be administered using a separate syringe to ensure proper dosing and effectiveness. Mixing can alter the action of the insulin, leading to potential complications. In a scenario where a client on sertraline begins linezolid and shows signs of serotonin syndrome, the priority action is to hold sertraline, notify the provider, and monitor for serotonin syndrome. The combination of linezolid and SSRIs can lead to this serious condition, requiring immediate intervention. For involuntary admission criteria, a client who is manic attempts to jump from a balcony and refuses care meets the criteria. This is due to the imminent danger to self or others, justifying involuntary admission to ensure safety and provide necessary treatment. When a client on clozapine reports a sore throat and fever with an ANC of 900,000 UL, the best action is to hold clozapine, place neutropenic precautions, and notify the provider. An ANC below 1,000 with infection signs requires stopping the medication and implementing infection precautions. For a client on phenelzine, the safest response regarding OTC cold medicine is to avoid decongestants and use saline spray and acetaminophen. MAOIs combined with sympathomimetics can cause a hypertensive crisis, making saline and acetaminophen safer options. In suspected epiglottitis in a child, the priority action is to keep the child calm, avoid oral exams, and prepare for airway management. Manipulating the oropharynx can precipitate obstruction, so maintaining a calm environment and preparing for airway intervention is crucial. After receiving IVIG for Kawasaki disease, the statement needing correction is scheduling the MMR vaccine next week. Live vaccines should be delayed after IVIG administration. Reporting fever, giving aspirin, and cardiology follow-up are appropriate actions. For a child with nephrotic syndrome, the effective order is an albumin infusion followed by furosemide. Albumin helps shift fluid intravascularly, and the diuretic promotes excretion, effectively managing edema and fluid balance. In teaching for cystic fibrosis at home, the correct action is to sprinkle pancreatic enzymes on applesauce before meals or snacks. Enzymes are necessary for digestion and should be taken with food. Avoiding hot meals and ensuring adequate calorie intake is also important. For a client with severe preeclampsia on magnesium sulfate showing signs of toxicity, the first action is to stop the magnesium infusion and prepare calcium gluconate. This addresses the signs of magnesium toxicity and prepares for antidote administration. In a 32-week pregnant client with placenta previa and bleeding, the priority action is to obtain an ultrasound and avoid a vaginal exam. A vaginal exam is contraindicated in placenta previa due to the risk of exacerbating bleeding. Confirmation with ultrasound is essential. For recurrent late decelerations on oxytocin, the first nursing action is to reposition the client to the left lateral position and stop oxytocin. Late decelerations indicate uteroplacental insufficiency, requiring immediate intervention to improve fetal oxygenation. In a TOLAC client on oxytocin with signs of uterine rupture, the priority action is to stop oxytocin, call a rapid response, and prepare for an emergency cesarean. Immediate intervention is required to address the potential for uterine rupture and ensure maternal and fetal safety. For a term newborn of a diabetic mother with low glucose, the best initial intervention is to start IV dextrose per protocol and notify the provider. Symptomatic hypoglycemia requires prompt treatment with IV dextrose to stabilize glucose levels. During phototherapy, applying lotion to prevent dryness requires intervention. Lotion can overheat or burn the infant. Instead, use eye shields, increase feeding frequency, and reposition every 2 to 3 hours to ensure safety and effectiveness of the therapy. For CCHD screening, using pulse oximetry on the right hand and foot with a pulse loss 3% difference indicating failure is accurate. Screening should occur after 24 hours of life, and significant differences require further evaluation to ensure early detection of heart defects. For a vigorous term infant born through meconium fluid, the best immediate action is to begin routine newborn care and skin-to-skin contact. Vigorous infants do not require routine tracheal suctioning, and standard care should be initiated promptly.